Okay, I think we're live. So now I'm just going to share it here to a couple groups quick. And if you are joining us, go ahead and drop a comment below. Let us know where you're joining us from today.
See if I can change the lighting in here a little bit.
One more share and we'll get started here. So those of you that are already tuning in, please let us know where you're watching from today. Where are you tuning in from? Okay, we are live. All right, welcome. Welcome everyone, and welcome Dr. Maynard. Today we are here with Dr. Perry Maynard from Integrated Brain Centers in Denver, Colorado. And today we're talking all about what's the difference between functional neurology and traditional neurology. It comes up quite often in my Facebook group. I feel so proud that after 7 years, my group now mostly knows what functional neurology is. And when someone new is in the group asking questions, they're like, find a functional neurologist near you. And then they're like, what's that? And so it's so cool to watch the group evolve, and like now they all know, 7 years ago nobody knew what it was, and now I feel like it's starting to become kind of a known thing. And people will be like, oh, I already have a neurologist. And it's like, no, it's very different. A traditional neurologist does a lot different than what a functional neurologist does. So Perry, where do you want to start? How do you want to start breaking this down for everyone?
Yeah, no, I think, I think the simple way we can go about it is we can start talking about some of the differences. I mean, if you look at traditional neurology, and unfortunately, probably a lot of people who are watching this feed have had probably multiple experiences with maybe one neurologist or many neurologists. And they might have had a really good experience. They might have had a really bad experience, unfortunately. And we'll kind of explain why that is. I don't think it's always necessarily the person themselves. I think it's the way the system is set up, and the way neurology is taught too. Because you have to think about it. If you're taught to look at something in a certain way, it's going to change the questions you ask and the things you do. Versus if you're taught another way, it may change it. So if you're looking at neurology as a whole, right? Neurology is the study, in essence, of the nervous system, okay? So that's the study of the peripheral nervous system. So in essence, the nerves that allow you to feel things, the nerves that allow you to move your muscles, everything in your spinal cord, all the way up into your brain, right? So pretty much everything from the nerve in my finger that goes all the way in my arm, into my spinal cord, up into my brain and my frontal lobe that allows me to appreciate music or art or whatever it may be, right? So neurology in simple standpoints is the study of that system. And if you look at traditional medical neurology, and this goes into healthcare in general, everything is looked at relatively black or white. And there's not a lot of gray area. What I mean by that is that they're looking for pathology, right? Medical neurologists, for the most part, are looking for a obvious pathology that can be labeled. Do you have a stroke? Do you have a tumor? Is this epilepsy? Is this a migraine, right? Something where a label can be put on, because that label comes with a treatment, right? Because at the end of the day, all of us go to a doctor, and all doctors really want to do is to be able to give an effective treatment. In medicine or medical neurology, really your traditional medical neurologist, their main form of therapeutics is going to be medications. And nothing wrong with that. There's a time and a place for medications, but that's really all they have in their toolbox, unless they're a neurosurgeon and they perform surgery. Otherwise, if they think rehab needs to be done, they'll refer to a physical therapist, occupational therapist, maybe a psychiatrist, right? But the really only tool that they have is medication, right? And the thought is using a medication to address some sort of black and white pathology. Where that fails a lot of individuals, especially in the TBI community, is there's not clear a lot of times black and white pathology. So how many people in this group are watching this might have had an MRI or a CT
Yeah.
and everything was normal, and therefore
Normal.
they're normal, right? But these are
Right.
static images, right? And these static images really only pick up things when things are really not good, but they're not looking at the human from a dynamic standpoint. And so I'd say that's one of the first differences before we get into more nitty-gritty details is functional neurologists have all the same kind of knowledge as medical neurologists and should have the ability to recognize the same pathology they can. So tumor, stroke, epilepsy, MS, demyelinate, right? All these things that we don't necessarily like. But on top of that, have more of an idea of the gray area. Because if you are dizzy and nauseous and you have headaches after a concussion, but the MRI is normal, okay, well, a lot of times they don't have any other tools in their toolbox, and like we'll talk about in a second, we look at the exam different as well. So on the unfortunate rare occasion that an exam is even done anymore, because all too often I hear the horror stories from patients that go to traditional neurologists and they get a diagnosis and I say, okay, well, what do they do to get that diagnosis? And a lot of times it just ends up being a conversation, a history, and I found that the examination doesn't happen anymore. I mean, I'll give you an example. My brother-in-law, he's 35, relatively healthy, and they were in Mexico on vacation, and he had what appeared to be a grand mal seizure out of like nowhere. And it was really, really scary. And I'm talking to my sister on the phone in Mexico and trying to guide her what tests to do, how to talk to the doctors. Unfortunately, there's a massive language barrier.
Yeah.
So pretty much was like, is he stable to fly? Okay. So he gets back to the States and goes to doctors. And he keeps getting a clean bill of health from doctors. And I was like, well, what did the neurologists do? Like, did they do an examination? My sister was like, what does that even mean? I was like, oh, did they touch him? Did they run a pinwheel on his head? Did they hit his reflexes? Did they watch how his eyes track, maybe flash a light in his eyes? And she's like, oh no, not at all. It was all virtual. We just talked over the phone. And so the big difference between functional neurologists is we take the standard examination that really should be done in all of medicine, and we look for those black and white issues, but we look at for functionally how do they look, right? It's no difference than you watch a Olympic lifter squat and their squat looks impeccable. And then maybe you watch someone who's never worked out a day in their life squat. They can still squat, they can get it done, but is it efficient? And is it efficient enough to where it's not going to cause low back pain or hip pain? Just like, is your brain working efficient enough that it's not going to give you headaches or it's not going to give you dizziness? So really, I'd say that's the big difference. Is there's a lot of similarities, but functional neurologists take those findings and they look at them with a little bit more fine detail. I'd say one of that's kind of the biggest thing. And we can kind of explain what the examination looks like and how that's different. But I say from a simple standpoint, a functional neurologist is looking at that gray area. And it's looking at, could your brain be working better? And how are all these networks associated? I think that's the other big difference too is, I'll have patients too where, neurologists will tell some concussion patients, don't do vision therapy. Vision therapy is quackery. It doesn't work. I've never seen it work for a TBI. The vision has nothing to do with concussions. And there's this like really huge disconnect in how everything's interconnected, how your eyes and your inner ear are connected, how your eyes and your neck are connected, how a balance disorder could cause memory issues, right? And you may be thinking that makes no sense. And a medical neurologist may say that makes no sense at all. Functional neurologists strive to stay up to date in all of the research and new theories around how the brain functions and how these networks interact. And what we really try to do is piece them all together to see that, okay, hub A and hub B, yeah, we can see the direct communication, but if you really look at all these pathways, hub A actually eventually indirectly connects to hub Z along this crazy long pathway. And that's how it makes sense how one's neck could cause double vision. I had a patient in the other day and she had some double vision just in one eye, and we did something to her neck and her double vision went away. Find me a traditional neurologist that would believe that that could happen, right? And functional neurologists have a really good understanding of neuroanatomy. I think probably some of the best understanding of neuroanatomy and neurophysiology, to where we can say that makes sense because of all of these different connections, versus the opposite is black or white. Your cerebellum does balance and that's it. Your frontal lobe does this one thing and that's it. When really it's this massive network. And that's the biggest difference, I would say, between a medical neurologist and a functional neurologist.
Yeah. And, I think for me, the most striking thing was, so when I went to the traditional neurologist, I was pretty early. I was only maybe 6 weeks into my brain injury. And she did do an exam. She did follow my fingers, shine the light. The one where you stand with your hands out and close your eyes. And I completely fell over. I mean, she caught me. She was right there. And then walk heel to toe, which I couldn't do. And that was it. Those were the only things she did. She did the reflexes on my knees and elbows. And then my report of findings is that I successfully passed all the tests. And I'm like, I did. And I was literally with her half hour tops. My functional neurology appointment was about 2.5 hours. It started with some background questions, and then all those tests that I just described, plus so much more, right?
Mm-hmm.
Like the pinwheel on the face, and we discovered my left side wasn't feeling the same as the right side. And I had complained to everybody about my vision, and I felt my vision was what was making me dizzy. And the neurologist literally told me that's not possible, that they're not connected, which now knowing what I know, it's just mind blowing. And just that initial exam with functional neurology, like I said, it was 2.5 hours, so in depth, so many things, but it was also so validating, because I just remember the first thing he said was yep, it's your eyes are not tracking together. And I was like, hallelujah, somebody believes me. I had been telling everybody who would listen, it was my eyes, and everybody dismissed it.
Yeah.
Not just the neurologist, the regular doctor, the eye doctor, everybody was dismissing it. So, yeah, it was very validating.
Yeah. No, that's
and I'm sure you hear that a lot.
No, that's actually a really good point. Actually, the patient I just was with before I hopped on here, it was kind of the same thing. Sometimes it's nice for people to see, wow, my brain doesn't actually work, right? Or I feel very slow cognitively. And then you can see these quantifiable metrics that also show oh yeah, okay, I wasn't lying. And you made the good point of the amount of reports I get that say within normal limits or grossly normal. Once again, that's that gray area we're talking about. They're looking for severe pathology, that's not good, right? So give you an example, a finger to nose, right? They're looking for
right
something like this. I'm going to make the argument that if you're 25 and relatively healthy and you're coming in and you get this little amount that maybe might be, once again, not a true ataxia or true cerebellar disease, but it's not good. It's not efficient. And it wasn't there before the head injury, and now it is here. And that's really, functional neurologists will talk about this, the kind of the 7 longitudinal levels of a lesion, right? Which is, how can we quantify as much of the neural axis, or everything from the nerve in my finger to my frontal lobe, right? And that's where we take all these different tests to be able to say, okay, all the peripheral nerves work well and they function at a high level. Okay, everything in the spinal cord, that looks good. Okay, brainstem, how can we quantify brainstem function? You're looking at eye movements, you're looking at inner ear, you're looking at facial expression, sensation, all of these different things. And then you have your occipital lobe, your temporal lobe, your parietal lobe, all these areas, there's different tests for it, right? And so we're looking and we're seeing, okay, do those look really, really good? Do they look terrible where we're concerned about a disease process? Or just like, hey, the left side looks decently well, but why does the right side look terrible? So also looking at asymmetries. And then the goal being is, how does that make sense for one's symptoms? Because you can find issues in all of us, but it doesn't necessarily mean it's related. Functional neurology tries to tie inefficiencies in the brain to find how is that related to one's symptoms. So once again, dizziness, headaches, nausea, fatigue, gait issues, balance issues, and then we can find that dysfunction and say, oh, that makes sense because that's what that area of the brain does, and then create a therapy program to improve function in that area of the brain, and then monitor to see, are these things getting better? And if they get better, is the patient's symptoms getting better, right? So you can see it's very dynamic. And it's funny, Dr. Stedman, the other doctor, always jokes with me, because my exams are very dynamic. So once again, a traditional neurologist is very static. I got to get from point A to point B. Like, I got to just check boxes. Okay, you can track, cool. You can roughly feel, cool. Okay, can you hear this vibration? Versus what I'm looking at, as soon as I find an abnormal finding, how can I change it? So like you said, if someone all of a sudden can't feel the left side of their face, I start playing in my brain these connections within the brain, and I say, okay, I know how these areas fire together. Can I change it? And if I can find something that changes it, it now gives me a window into that function, right? So that's the big difference too, is you find abnormal findings, and then you find what things make them better or worse. And so as you're going through the exam, you're literally getting this beautiful dynamic picture of how the brain is actually working versus a static thing, right? You don't just examine someone just seated. You stand them up, you put them in dark, you put them in light, you make them laugh, you maybe load them, maybe I'll have someone walk and I'll have them do arithmetic. And right, so now I'm looking at, when I add cognitive load, can they still walk appropriately? Can they balance, right? So it's finding these things that don't work, but then challenging them, because then that can allow you to know what might be helpful therapeutically. So that's a cool difference between functional neurology and traditional neurology as well, is how dynamic it is.
Mm-hmm. Yeah. And getting to that point of like, if you can get it to change, that you're getting into the right system. For me, getting my dizzy and balance stuff under control, especially the dizziness, I would say the dizziness was probably my most debilitating symptom. Because when I was dizzy, I really couldn't do anything. It just, it would eventually make me nauseous, and it made doing things hard. Where like headaches were more debilitating, but I didn't have headaches all the time, right?
Mm-hmm.
Like they come and go, where that dizzy was just constantly there. And I kind of equate it to having too many tabs open on your computer, and nothing can work efficiently. Yeah. And nothing can work efficiently when there's 20 things open. Nope. So you have to start closing things down. And so when we got that dizziness under control, it felt like it opened up a lot more. Like my memory started improving, my balance got better. And like over time, like everything, it was like the tabs started shutting down, right? Like,
what are you talking about? There's no connection between any of those, Amy. I don't know what you're talking about. No, it's so true that you said it perfectly, and we see that clinically all the time. That you start closing down those tabs or improving inefficiencies in the brain, and it literally just comes back online. and a lot of people say that that can't happen or that's not a thing. But it does happen, and it makes sense. If you really stay up to date with neuroscience and neurophysiology, it makes total sense. It's all just how you decide to look at it and how you decide to interpret it. So it's like I said, it's pretty cool stuff.
And you mentioned at the beginning of the talk how the healthcare system kind of sets neurologists up to fail too. Like, with in a traditional system, you get like a 20-minute appointment with the doctor. A
If you're
PT
lucky.
appointment, yeah, a PT appointment's typically like 45 minutes. And that's not enough time. 20 minutes, like you barely can catch the doctor up on what has happened since the last time you saw them in 20
Yeah,
minutes.
yeah.
Where with you guys, it's an hour and a half appointment, and you're doing lots of things.
Mhm.
Sometimes the appointments can be really intense, sometimes they're not quite as intense. But it within that healthcare system, it is, you're kind of set up to fail because it's in and out. Like,
Yeah,
how many patients can we get in a day is basically how a traditional clinic is set up.
yeah. I mean, between that and then what you'll get reimbursed for. I mean, and that's the
From
problem with
insurance.
the insurance realm is, you
Yep.
have standards of care, right? And standard of care is pretty much insurance saying this is how you treat this. So if it's a migraine, the standard of care is a gamut of medications that you have to fail to get to another medication. So really, why would they talk about diet? Why would they look for someone being anemic? Because honestly, they're not going to get paid for it, and that's nothing against them, right? They got to make a living. They have to keep their doors open,
Yeah.
and so they have to play this insurance game. And insurance, it's kind of funny that some bureaucrat is literally telling a doctor what to do and how to treat, and
That has
granted,
no medical experience,
yeah,
right?
and
Mhm.
sometimes you have medical practitioners who are on the boards of those, sometimes you don't, or they're so far removed from clinical practice.
Yep.
But yeah, I think the time, I mean, if you gave me 15 minutes with all of my patients, I would probably fail as well, because
Mhm.
it just is not enough time. I mean, I had a patient in today, I talked to Lindsay and I was like, hey, give me an hour. That should be good. Jasmine will see her for like an hour before to get some testing done. And I got done with her and I was like, no, I'm sorry. I was like, we actually need way more time. There's so much to look at, right? There's so many pieces to the puzzle besides history and everything they've done and all the tests that they've done that have failed. We have to understand that, and then we have to try to map out as much of their neurophysiology as possible so that when we make a plan, it makes the most sense of giving us the best probability for a successful outcome. Versus if you have 15 minutes, you're just guessing. You're reaching for, and you see this with doctors where they hang on to a comment that a patient made, and I'm like, how'd they get that diagnosis? Oh, because you said this one key word. They ignored
Mhm.
10 of the other keywords that you said, and they just heard the first one. They said, oh, yep, that's a vestibular migraine. Okay, here's the protocol for vestibular migraine. And they ignored the 10 other things that you said afterwards because there's not enough time and they have to find a treatment for you. And so I think a majority mean well. And most people get into medicine to help people. It's just unfortunately a broken system.
Yeah.
And then I think sometimes they cannot be the nicest because they're frustrated. They have burnout. Because then if you don't feel like you can help patients and your outcomes aren't well, you're not going to be happy. It's like it happens to all of us where if you go through a time and patients are difficult and things are difficult, you get burnt out and you get compassion fatigue. So I think the system burns doctors out. And then that makes them sometimes not the most pleasant people to be around.
Yeah. Yeah, it's a fair point. Um, so anyone that might have questions, you can go ahead and drop those in the comments. I am trying to monitor those. It's kind of fun to see where everybody's watching from. We've got South Carolina, Texas, Ontario. We have Duluth, Minnesota. Yay, I love Duluth. Um, And so we do have a question that asks, what's the difference between a TBI and an AVM?
Perfect. So a TBI is a traumatic brain injury, right? So, and you have different grades, but ultimately with the TBI, anything that it doesn't have to be a direct necessarily hit to the head, but anything that creates a shear or rotational force in the brain that in essence disrupts these highway connections within the brain. So a traumatic brain injury is a brain injury that can be from a traumatic cause, right? Whether a car accident, whether a fall, whatever it may be. Okay. An AVM is an arterial venous malformation. So an AVM, a lot of times can be genetic in nature, and it's a malformation in arteries and veins within the brain. So there are some points throughout the body where arteries and veins kind of come together at like capillary beds. So if we think about in the body, right, your arteries take maybe blood to my hand, it goes into the tissue, there's capillary beds, and then the veins take blood back into my heart to reoxygenate. So there can be malformations, AVM, and then that can cause some issues because it can affect blood flow, or it can weaken or disturb the vasculature and cause things like aneurysms, right? Which are not good because AVMs can rupture. And if they rupture, right now you're bleeding out in essence in your brain, which is not good. And they can be very dangerous and deadly. Sometimes they can be benign. Some individuals go through life with having AVMs and they never knew that they had one. And in other individuals, it's a ticking time bomb, but it's in essence a malformation between your arteries and your veins, which is going to affect the way you oxygenate and get blood into your brain in simple terms, versus the other is a traumatic injury to the brain where there is shearing. So think of your brain like a towel and you're getting wringing out of that towel. But the problem is in that towel, there's all these high speed connections like high speed Fios internet.
Yep.
And
Yep.
you're breaking those connections and now it's becoming AOL dial-up.
Great analogy. That was a really good analogy. We have another question from Lisa. She said that she is post TBI with symptoms still lingering years later. If I haven't recovered after 19 years, is it too late to hope for recovery?
It's a great question. I don't think it's ever too late. It depends. We definitely know that, I'll give, for example, in strokes, which are different than TBIs, but after 2 years in a stroke, 2 to 5 years, can sometimes be very difficult to regain function, or just more difficult. I'd say the same with the TBI. The longer you go, it can make things harder, but the brain is always plastic. Unless you have a disease process that affects growth factors in your brain, which there can be ones, you can always make new connections, right? So I would argue that changes can be made. Now, it's hard to say how much change, but time alone, yes, it makes it difficult, but it doesn't totally limit your ability to make changes, right? Whether those changes could be a 20% change, but it's a change. So I would keep hope, especially if you haven't been to a functional neurologist or someone to really examine all the facets and without knowing your symptoms as well, and kind of what happened. But I'd say, yeah, I think there still is some form of hope there. And I think change can always be made in the brain, right? It's kind of like the can't teach old dog new tricks. I don't think that's the case.
Right. Yeah. I was 2.5 years before I discovered functional neurology, and I had been told by the neurologist at a year that was probably the best I was going to get. And we know that that's just, total BS. We know that neuroplasticity can happen forever. And so, I wasn't sure how far I'd get in my recovery. And that has been 6 years now. And I'd say in the last year, because I thought I had hit my like maximum recovery, which I was okay with. I was, I was back to a functioning human again. But in this last year, I feel like I made another big step. And I think part of that was I came out to see you last summer. And there was just one little thing going on with my dizziness. Like it was when I would lay down at night and turn a certain way, I would feel that like moving. And you did a little tweak, and I mean, I just feel in this last year I had another like step in my recovery. So I encourage anyone, like, it's never too late to try, and you might not get back to 100, but if you're down here at like 30% functioning and you can get to 50, isn't that worth trying? So that's my opinion.
Yeah, no, I agree. I think you're completely correct.
Refresh, see if there's any other new questions. She said, thank you. You're very welcome, Lisa and Bill. All right. Well, Perry, this has been a great conversation. I think everyone got some, some good info today on the difference. Because it is confusing, we've been taught our whole life to go through this traditional medical system, and you go to your doctor and they refer you to the neurologist, and maybe you get referred to PT or something, but anything outside that box, isn't explored within the traditional system. So you have to get outside that system, because there's a whole other world out there of healthcare providers. So
unfortunately, there's too much politics, and there's just too much issues of why can't we all just get along, and
why can't we just all play together?
Just to help the patient. Too many egos, too much, this is the cultural hierarchy, which is a shame. But I think it's changing. I definitely think it's changing. And people are speaking up because people are tired of not getting the care they deserve. So I think people are starting to be like, this system doesn't work anymore. I'm open to what else is out there. So I think it is changing.
Definitely. All right. Well, Perry, thank you so much for being here. We'll see you again next month, but thanks so much for sharing today, and have a great day, everyone. And I will see you guys next month.